Good afternoon, and welcome to today's FASD Awareness Webinar, Recognizing the Red Flags with the Division of Mental Health, Developmental Disabilities, and Substance Use Services. Before we get started, here are a few reminders about the webinar technology. Please make sure you're using a computer or smartphone connected to the internet and the audio function is on and the volume is turned up. Please make sure your microphone is muted for the duration of the call unless you're speaking or asking questions. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. We will answer as many questions as time allows after the presentation. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Danette Steelman Bridges and Susan King Lanier. For closed captioning options, select the closed caption feature located on your control panel. To adjust your video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda topics include introductions and then a presentation on identifying the red flags of fetal alcohol syndrome disorder. This will be followed by a panel discussion. There will also be time for questions. At this time, I'd like to turn it over to Ginger Yarborough, IDD, TBI, and Olmstead Director for the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
All right, thank you, Dina. Good afternoon, everybody. Forgive me, I'm facing a cold, so I may sound a bit funny. So I will try to speak up a little bit. Like Dina said, my name is Ginger Yarborough. I'm the Director of Intellectual and Developmental Disabilities, Traumatic Brain Injury, and Olmstead here at the Division of Mental Health, Developmental Disabilities, and Substance Use Services for North Carolina. I started my career as a direct support professional, or a DSP, and have since worked as a supervisor at a provider, day program, was a care manager, and in quality management at what is now a tailored plan. But I made the jump over to the state in March of 2023 and have learned quite a bit and continue to learn a lot from our community. Before I talk a little bit about FASD, I wanted to put in a bit of a plug for our DMHDD SUS strategic plan. It has been officially released and it is posted on our website. It has been a labor of collaboration and mutual appreciation for where we are now and the vision for our future. So I would invite all of you to go read, look over it. If you're interested in hearing more about it, please join our upcoming webinar on Wednesday, October 9th at 6 p.m. and we can drop a link into the chat for everybody to sign up. All right. So again, welcome. We're really excited to have this webinar. September is Fetal Alcohol Spectrum Disorder Awareness Month, or FASD Awareness Month. FASD faces so much misunderstanding in the professional world and in the community. And this webinar is going to give us some clarity, help folks recognize the red flags, as the title suggests, of FASD. When I started in the field, I really had no idea about FASD outside of what I read in textbooks, and reading in textbooks and actually working with people are two very different things a lot of times. Though looking back, many of the individuals I have worked with probably had FASD, but were undiagnosed. Through early detection and recognition, supports and services can be tailored to the individual's needs. And many people get caught in the system as having failed treatment, when in reality, the treatment wasn't tailored to their FASD needs. So we hope through this webinar, you'll find it informative and that it helps prepare everyone to recognize the signs for better detection and informs how people work and build relationships with those with FASD. And with that, I am going to turn it over to Kathy Hotelli, our fearless FASD expert, and let her introduce herself. Thank you.
Thank you, Ginger. And even though she and I have not been in the same place together, as far as I know, I'm ailing today too, so I'm hoping my voice hangs in with me since this is my second presentation today. It's a busy month for us because, as Ginger said, this is International FASD Awareness Month. I have to say that as in my training as a clinical and counseling psychologist, I never learned anything about FASD, nothing. It was never mentioned. And then this little girl came into my life, and I had the wherewithal, I'm not sure why, to think that perhaps she was exposed to alcohol in utero. I'm not sure where that idea came from. And for 10 years sought her a diagnosis that was accurate for her. I am trained, as I said, as a psychologist and have primarily worked in university settings, hospital, adjunct roles, and had a private practice and taught graduate school as well. Originally, my specialty was eating disorders, and in the last 17 years since I've been home with my daughter, it is definitely fetal alcohol spectrum disorder. I want to say that Ginger did an outstanding job of giving the basics that we want everybody to know and about what she learned since she was in more of a direct support service role. If we could go to the next slide, please. Okay, next slide. Okay, so drinking during pregnancy is the #1 cause of intellectual and developmental disabilities. This is really unknown, as evidenced by how hard it is for families to get an individual, a family member diagnosed, how many physicians continue to say it's fine to drink a little bit or in moderation while a woman is pregnant, and some other factors that I will be pointing to as we move along. Next slide, please. Phil May, who is from UNC and is based out of Kannapolis, and his colleagues did a study that was published in 2018. And what they looked at in 4 different areas of the United States, California, the Northwest, the Midwest, and the South, which, as he says with a wink, might be North Carolina, found that 1 in 20 first graders, when evaluated, had an FASD. 1 in 20. That's 1 child at least in every classroom. That is, to me, astounding, especially given so few people are aware of this diagnosis. He also says that through his post-statistical analysis, that if the people who had not allowed their children to be diagnosed would have been in the study, that the number would be much higher. And that is sobering. We also know that there has been a large uptick in drinking during COVID. And one agency, provider agency that we work with, has told us that they are seeing the results of that and having more children coming in to their care that appear to or have been diagnosed as having a fetal alcohol spectrum disorder. Next slide, please. However, only 10% are diagnosed properly. That means 90% of all people, and this includes adults, because obviously this is not a new phenomenon, women drinking during pregnancy. 90 people have either a misdiagnosis, that means a bevy of other diagnoses that are mental health diagnoses that are may coexist, but maybe just aren't quite right, or they have a missing diagnosis, and that is exposure to alcohol, which is represented by fetal alcohol spectrum disorder. Next slide. The primary myth is that all with FASD have distinctive facial characteristics. And as you can see from the graphic here, that is the tip of the iceberg. Only 10% of children, or of those that have been exposed to alcohol in utero, have the facial characteristics known as fetal alcohol syndrome, which is one of the diagnoses under the umbrella term fetal alcohol spectrum disorder. That is obviously a very small proportion. And we might consider those children fortunate in that they have an earlier diagnosis because they exhibit the facial characteristics, and most physicians need to know that that is a sign of prenatal alcohol exposure. Next slide, please. So FASD, fetal alcohol spectrum disorders, is an umbrella term. It is not a diagnosis. It is in Canada, but it is not here. Included within that umbrella term are 5 different diagnoses. 4 of those are from the ICD, and 1 neurobehavioral disorder associated with prenatal alcohol exposure, that's a mouthful, is in the DSM. So those are the 5 diagnoses that one would have to be considered in the topic that we're talking about today. Next slide, please. This is a whole body diagnosis. It is within the last 5 to 7 years that there really has been much more recognition that alcohol affects the whole body when the fetus is exposed to alcohol in utero. That is not surprising, since the alcohol goes throughout the body, but it is not something that really has been featured and studied until the adult change makers out of Vancouver, and that is now actually a worldwide group that looks at and examines individuals and surveys individuals with a diagnosed FASD. Their studies came about from hanging out together at the Vancouver International FASD Awareness, Vancouver International Conference on FASD that has occurred for many, many years. Starting this current year, it's now in Seattle and will be in Seattle in the coming years. But they started comparing the different troubles they had with their body. And as a result of that, they instituted a survey. The questions that they asked were questions that they devised. They did have consultants, experts in the field to ask questions of, but it really is wholly their research, and their questions were, the statistics were done by an expert in the field. But this is really they are the ones that brought to our awareness that this is a whole body diagnosis. And as a result, including last week, we heard in DC when we were at FASD Impact Week that more studies are being done to look at the physical body, not just the brain, and what is being affected. Next slide, please. I want to say that failure to diagnose is a failure to treat. And as Ginger mentioned in her introduction, the realization that these individuals are not being treated adequately or appropriately because they are not diagnosed appropriately is very important. And I want to show some of the implications that has for the 1 in 5 children in foster care nationally that has an FASD, but most of them are not diagnosed, as indicated by my previous slide. Next slide. So nationally, 558 infants and children enter care each day in the US. That would mean that 1 in 104 have FASD. We know in North Carolina that 42% of children in care have had 2 or more placements, and 22% have had over 4 placements. And I read about someone who had like 14 placements up till their age of 18. I think these children are moved from home to home because of the problematic behaviors which foster parents don't feel like they know how to handle. And it is our stance at NCFASD Informed that the diagnosis of FASD would indicate that different parenting tools are needed, and that we could teach those foster care parents approaches that will help them in dealing with the children in their homes as foster children and maybe subsequently adopted. And that first we need to do the screening and then the evaluation, if that is so indicated by the screening, to achieve a diagnosis, and then teach the parents a different way of approaching their children. Next slide, please. So how do we recognize FASD? Next slide. The first, obviously, is the presence of facial dysmorphology, which I just addressed, and that is fetal syndrome disorder, FAS. Another one is confirmed prenatal exposure to alcohol. Now, I say that's a red flag, and of course, not everybody who is exposed to alcohol in utero has an FASD, but what is interesting to me is how it is often glossed over, even if it is known that the child was exposed to alcohol, and no further examination of the effects of that are pursued. Confirmed maternal drug use. That is because women who use drugs also use alcohol. The opposite is not true. Everybody who drinks does not use drugs, but alcohol is socially appropriate, approved, and one can do that in public. And often those who use drugs use alcohol too, to a greater or lesser extent. Again, remember, this is a spectrum disorder, and the comments I'm making today affect, the amount of alcohol obviously affects the unborn child, but also affects the amount, affects the fetus. We also say possible maternal alcohol and drug use or dependency, because we don't always know that. I think what I want to point out here is that possible is because we don't always know unless we get in, dive a little deeper into the maternal history of the parent. Sometimes that is because these questions are never asked, or other times women may not want to admit because of stigma or fear of having their children taken away, or other adverse effects. Next slide, please. Biological sibling with an FASD diagnosis is definitely a red flag. It may be an older child and the next child has more effects. Maybe the older child hasn't been exposed, but as the pressures of having children grow, the mother may consume alcohol and more. The exceptions to this would be for women who are incarcerated for most of their pregnancy. I know a family who has 3 biological siblings. The middle one does not have FASD. She was incarcerated almost immediately upon becoming pregnant, and was in jail throughout her pregnancy, and so therefore she has had no exposures, but her 2 brothers on either side of her do. In foster care, 558 enter the system daily and 104 have FASD. So it is a red flag that that child is in foster care. And then also domestically or internationally adopted. We know that these are children that are relinquished for various reasons, and drinking and FASD occur throughout the world. Some in greater degrees than others, but if one has an adopted child, there is some likelihood that they have been exposed and have an FASD. Next slide. The final big red flag that I want to talk about is multiple co-occurring disorders. I believe I mentioned that my daughter was diagnosed at 10, which is 20 years ago, which is when Google came to into play. And up until that time, I had been saying to every practitioner she saw, I think she's been exposed to alcohol in utero. And everybody was either no or shrugged their shoulders. And I think they were looking for the face. She looks typical. So what they knew about was fetal alcohol syndrome, or perhaps they didn't know anything about FASD, period. I'd like to give them the benefit of the doubt. But in that 10 years, she gathered 10 diagnoses, mental health diagnoses, starting with ADHD. And I said, well, she certainly has some of that behavior, and the medication did address some of that behavior. I said, but I think there's something else. I really do think she's been exposed to alcohol. Well, after seeing 10 to 12, 14 practitioners, mainly at Northwestern Hospital and University of Chicago, my friend and I were looking through Google and we found a clinic 8 miles from everybody she had seen, basically. And we walked in with the records and she had a physical exam and she was diagnosed. They knew what they were looking for. They knew about FASD. And I say multiple co-occurring disorders because, you know, the medication and the talk therapy don't really seem to work. They work some, medication can work some, or it can work intermittently, but it doesn't necessarily resolve the problems that are being presented in the family and school and socially. And talk therapy, my daughter started started meds at age 5, and until she was 12, and we moved here to North Carolina. We started up talk therapy again until she announced on her 3rd visit, I'm not doing any of this role playing and I'm not going to change, so there's no use of us doing this. So obviously she was not responding to the interventions. And I had seen that along the way, that she was having, she was in social groups at school, led by the speech language person, but her interactions with her peers were not changing much. They weren't negative, they just weren't age appropriate. Can we move to the next slide, please? So what are the common symptoms? Next slide. For infants, I'm going to let you read through these. I'm not going to speak to each one of them. Now you may see these and you look at them one at a time and you say, well, you know, that happens. I've seen that. Or, you know, maybe a couple of these. But again, remember, a child exposed to alcohol is not going to have every red flag, but these are some of the things that we see in infants. And they are the beginning of, I guess I would call it a pyramid that may develop more and more signs, red flags, that there actually is exposure to alcohol. Next slide. By the time they get to preschool, these are some of the things that we see. Again, maybe not all of them, maybe many of them, but you will see these kinds of difficulties. I think one that most often shows up is the difficulty with changes and transitions. And I think Catherine, our parent, is going to speak to that, that routines are a must in the family, or else there's a lot of emotional dysregulation, which results in what we call rages. And, you know, most of us know about tantrums that children have around the age of 3, the terrible threes. But these rages may start earlier and may continue, or they may kick in later when something big has happened, when there is a big change or transition. And that's the example I would make of my daughter. We moved here at 12. She had never had really any kind of tantrums or anything. She was pretty easygoing, but once we moved, that was a whole different thing because everything in her life was upended. And the fine and gross motor control, that often, when you have that in a child, is going to be addressed rather quickly compared to, and noticed more than perhaps some of these other things. And both OT and PT may be started to try to mitigate the effects of the poor motor control. Next slide, please. Okay, school-age children. We start seeing some things that are a little different than younger children. Around the 3rd grade, we know that executive functions become much more important. So while up to 3rd grade, they're learning to read, and they have a lot of picture books and just learning to recognize and different words and sets of words and sentences. But at 3rd grade, we expect that they're going to comprehend those words in a different way. So as we get into chapter books, there's a storyline there, and as they get older and older, the development of characters. You know, I'm reading a mystery right now, which is my go-to, helps me escape some of the things in my life. And I'm like, oh, I think it's this. I think this is who did it. And it's, it's abstract thinking. I'm putting the pieces together from the different chapters, from the different characters, and I'm moving forward. I'm not just reading the words, I'm getting something from it. And you're often going to see that. Another is receptive language. Often you're going to see a delay in receptive language, a very slow processing speed. We say our kids are 1 second kids or 10-second kids in a 1 second world. That is, they're sorting through the words and it takes time. And while you may say to a typically developing child, I'm going out to the store, I'll be back in a few minutes, they're going to get all of those words and understand what's going to happen. And our kids are slowly processing that, but there's also the difficulty of getting about 3 words out of every 10. So they may hear out, they may hear store, they may hear minutes, which is the last word, but they may not have the whole picture, so to speak, as to what's going to happen right now. One of the examples I often give to parents is that to say, they often say, walk, don't run. I have said this to myself, walk, don't run. Well, there's 3 words. The most recent is the one they're going to remember is run. And they're going to keep running, probably. Not all of them, but they will. And so you want to say, don't run, walk, or just walk, please, or please walk. And that's going to result in a different, hopefully, kind of behavior. Impulse control gets more problematic as they're in older elementary, middle school, and high school, seeing that the child needs repetition upon repetition to learn a new skill. Some say 20 times before they get it. Sometimes it's more, truthfully, and sometimes it's less. But needing constant reminders, not being able to multitask, needing to give one instruction at a time. This is what we see with school-age children. Next, please. Older children and teens may advance much more because they have early diagnosis and interventions such as physical therapy, occupational therapy, speech language therapy, social skills therapy, families moving forward, which is an evidence-based modality, the ALERT program. These may mitigate the symptoms that I've talked about. I want to say that if a child is not diagnosed until their teens, if they've had physical therapy, occupational therapy, speech therapy, they're going to be in a better place. Or if they have had early intervention, 0 to 3. My daughter was 2¼ pounds, 3 full months early. So she got early intervention in our house. And I think even though she was not recognized as having FASD, those provided the building blocks then to move on to physical therapy, occupational therapy, speech language therapy, social skills training, which she had through much of her schooling. She did not have these other 2 programs because they weren't developed at that point. But I think that did help mitigate some of the symptoms that I talked about up to this point. Next slide, please. And other symptoms do not dissipate or may become worse because of the increasing expectations that we have of older children, adolescents, and adults. As they age, we expect them to be more independent, to leave these gaps behind, but it's not going to happen. And I think as we see the child get older, and they get more frustrated because they realize they're not as like their peers as other, they're not like their peers, they get frustrated, and we may have more behavioral symptoms of the FASD. Next slide, please. These are executive functions that I mentioned before. We need these across our lifespan. And as Ginger mentioned, this is a disability that is a lifetime disorder. And these are all impacted. Impulse control, decision-making, judgment, very, very difficult, as are the others. Let's move along. Dysmaturity, that is the difference between someone's chronological age and how they act. That continues. I would say that my daughter, who's 30, probably acts 18 sometimes. Sometimes she acts in her 20s, and sometimes when she gets really upset, she acts much younger. Literal, take things very, very literally. So that's when analogies and metaphors pass them by. They don't know what's meant. They don't really know what's being discussed. They may miss jokes because of that. The slow processing speed that I talked about, and the impulse problems. Move on, please. Okay. Now we are going to hear from Susan Shepard Carlson, who is the FASD, Fetal Alcohol Spectrum Disorder United Board Chair. That is our national group of which we are an affiliate. She is also a retired judge. Unfortunately, she cannot be here today, so her portion is recorded. She had to leave Minnesota and fly down to her place in Florida because of Helene coming to hit. So she taped for us. So that's going to be embedded, and someone is going to show that.
Good afternoon, everyone. I am delighted to join you via recording, not in person, for this really important webinar on the red flags having to do with fetal alcohol spectrum disorders. I want to thank Kathy Hotelling for inviting me to speak to you. She's been a tireless advocate for many, many years, and these sessions are incredibly important. First, a little bit about me. I'm former Minnesota's First Lady, as well as a former juvenile court judge. And it was the intersection of those two roles that got me involved in this issue more than 2.5 decades ago. And here I am, many years later, before you, advocating for this disability. I'm currently chair of the FASD United Board, and as you can see from my backdrop, I'm also a policy wonk and have been working with advocates for the past 3 to 4 years on the FASD Respect Act, which I hope you can get involved in. We're, I think, close to the finish line, but it is setting national policy on this disability, which, as you're learning today, is the most common developmental disability in the United States and in the world. And the recognition of it is woefully inadequate in our systems of care. I've worn many hats, and I just have told you a little bit about two of them. I've also worked on the coordinating committee on FASD Justice Work Group, and have done a lot of training around the country in developing a curriculum for those in the justice profession. I'm not sure where you all sit with your professional lives, but as you will find that you will find FASD anytime that you're in our systems of care, including education, justice, mental health, substance abuse, whatever. And I know it seems complicated about recognizing, because most of the youth are not recognized, and it's because our systems of care are not geared for recognizing. And so Kathy wanted to have me talk to you a little bit about the red flags that I saw that got me involved. And I know she only wanted me to talk 10 minutes, and I'm going to keep it to that, just to kind of whet your appetite. But I do want to tell you a little bit about the calendar that I did when I first began this journey. And that was the detention calendar. And that's where kids have come in on new offenses, probation violations, not doing court orders. So it's your more at-risk youth. And they did a profile, Hennepin County, Minnesota, and that's where my court was, of the youth the year before I did my calendar. And I just wanted to give you those statistics so you can have an idea. 2/3 of the youth that I saw were diagnosed with conduct disorder, oppositional defiant disorder, attention deficit disorder, emotional behavior disorder, or learning disability. So that'll tell you that the youth from that population and those with an FASD would have often similar labels or diagnoses. 57% were lower average or lower RQ, but more importantly, 75% came from family histories of substance abuse, domestic violence, child abuse, neglect, criminal behavior, mental disabilities, etc. And 40% came from a child protection background. And so before court, I would look through the court files and read the psychological evaluations, because that's how we determine what we're going to order during our court hearings. And I was struck by the fact that the psychological evaluations were more concerned about anything that happened after birth, and the mention of a diagnosis related to a prenatal alcohol or other drug exposure really was not dealt with. And so I was particularly interested in alcohol, so I just got myself educated. And at that time, Congress had just passed a bill on the first FASD programs in 1998. Ann Streichholz was beginning with her secondary disability study. And so there was a lot of activity. But I just want to tell you some general observations that you might think about in FASD in your work. If a child seems immature or naive, if they're if they're slight, they're short, this isn't always observed, or growth delays. And I know that there's been a lot of focus on facial abnormalities, and that is a very small percentage, about 10%. So don't get caught up in thinking about any facial abnormalities. And I think the eagerness to please or stubborn resistance to the obvious. I think inability to concentrate or provide a coherent, detailed narrative when you asked them in court. And then again, history of being in child protective services, especially if there's a result of parental substance abuse. I think if they have a history of behavior problems or learning disabilities, they have developmental disabilities, and failure to remember what we tell them from appointment to appointment. I think if they have multiple foster care placements, I think if you're in the justice system, if they have an offense that's strongly suggestive of a cognitive impairment, because these offenses were marked by impulsivity, they had little or no plan, no exit strategy, and a high risk of detention. If they're very impulsive, ADHD is one of the more common diagnoses, and explosive behavior. If they have ongoing problems in school, and if they have inability to follow rules and stay safe and healthy and behave and behave and interact well with others. They have a failure to connect what they did to the legal consequences. For instance, if they've decided they need a ride home, they find a bike and they get on the bike and they ride it home. They don't think about that's not their bike. And a long history of probation violations. So those are just the red flags that that I would highlight. I wish you well in this journey with this disability, and I would leave you with one suggestion that where we can begin to start recognizing these youth, begin to look at where you can input in any documents that you're doing in looking at these kids, and asking the simple question, what was the prenatal alcohol history? And there's all sorts of trainings on how you can ask that in a very sensitive manner. We did a screening project in our juvenile court, and 80% of, and they were birth mothers, would answer the question. And we had so many, our first year, we had to narrow down our population. And so we chose those youth that had failed what we call the MACI-2. It's a mental health questionnaire, which is required by the state of Minnesota. And if they failed that, then we would screen them. And 40% of those youth actually ended up with a diagnosis. And then overall, we had about 25% of the youth that screened positive. So this is a significant issue in our systems of care. And this training and these red flags will just begin that journey for you. Again, I thank you for your work, and I wish you good luck. And I thank you for having me here today. Thank you very much.
Okay, well, I can't thank her back so that she can hear it. However, I have just sent her a text saying thank you, and to hang in there with protecting her property in Florida. Next, we have Dr. Valdez, who is a developmental behavioral pediatrician from Duke University. You need your.
Sorry about that.
Oh, you're muted again.
Okay. Can you hear me and see me okay now?
Yes.
Okay, wonderful. Sorry about that. Thank you so much for inviting me to speak on FASD, red flags, characteristics that I see as a developmental behavioral pediatrician on this very under-recognized entity, I think even in the medical profession. I've been a board-certified developmental behavioral pediatrician since 2006, and I really had excellent and wonderful training, but did not really gain knowledge about FASD until I did my own professional development throughout my career based on children that I was seeing. in essence, every child that we see in a developmental behavioral clinic, and I see children all the way through age 18, from young age through 18. It is very much a standard part of our intake process now to ask about exposures in the birth history. Not doing so would really be an incomplete history, it'd be an incomplete diagnostic process. And so a lot of times, a lot of our birth history involves, were there any exposures to alcohol or other substances during pregnancy? And families might say no. What I have since learned is that the way to really ask it is before you found out you were pregnant, had there been any intake of alcohol in that period of time, close to the time that you found out that you were pregnant? And I often find that people will say yes. So this is just standard procedure. Every family that I see in a specialized developmental behavioral clinic, because I see children with emotional dysregulation, behavioral dysregulation, intellectual and learning concerns. The array of characteristics that we see in kids with FASD is really variable, but basically, if there is documented exposure to alcohol during pregnancy and developmental behavioral concerns, pretty much this child has FASD. You know, the specific entity in that case would be alcohol-related neurobehavioral disorder, but it is part of FASD. The characteristics that I see really echo what has been said. It will be the hardest to treat ADHD one will ever see. It will be a child that requires really, really high doses of traditional ADHD medications. Maybe traditional ADHD medications just aren't cutting it, and you have to involve perhaps even an antipsychotic because of the level of impulsivity that's impairing their functioning. As was already said, I often see impaired antecedent and consequences. So just having an impaired sense of heeding consequences. Consequences don't seem to impact the individual. And so they keep going through the same problematic loop. For example, they might have a predilection to take things everywhere they go, and they're not heeding consequences. So then it turns into, quote unquote, a categorization of stealing. And then there is concern that they will be arrested as they get older and older, and they are not able to control that behavior. So it can often be this inability to heed consequences in such an impaired way that really can endanger their position in society. Sometimes there can be a lot of diagnostic uncertainty between the social interaction difficulties of FASD versus autism. So that can be a lot to disentangle, but there can really be some differences. For example, in someone with autism, one might see impaired eye contact, or the absence of gestures, or the absence of other social nonverbal communication. An individual with FASD might not lack that nonverbal communication skills, but they still struggle to organize their social interaction. They struggle with socially sizing up a situation. They still have social cognitive deficits. They have difficulty interpreting body language or social cues. That can really be part of it too. We can also see individuals with just a multitude of diagnoses just embroiled together. You know, really severe ADHD, anxiety, maybe disruptive mood dysregulation disorder. I am involved in some statewide work in multidisciplinary arena evaluations of children with IDD, or intellectual developmental disabilities. And these are cases that come to our team. These are children, individuals who've just had some really devastating situations, a lot of complicated characteristics. And they perhaps have had to have police involvement. They have had physically harmful behaviors toward others, which resulted in removal from the home. And in looking through their assessments and the evaluations that they've had, you can see a litany of psychiatric diagnoses, you know, including the ones that I've mentioned: ADHD, anxiety, disruptive mood dysregulation disorder, borderline personality disorder sometimes, just a lot of psychiatric diagnoses. It's really something in this particular array of evaluations I've been doing for the state. We've done 5 so far this year, and 3 out of 5 I ended up diagnosing with an FASD when it had never been mentioned before in these cases. And these are, and these involve individuals who are 13 to 19 years old, you know, so it's not that they're very young. They are teenagers, sometimes young adults. So it is just not being recognized. You know, so even within the medical community, there's really been an effort toward improved educational techniques so that healthcare providers know to ascertain this information to make these diagnoses. A lot of times healthcare providers will confuse or conflate fetal alcohol syndrome with fetal alcohol spectrum disorders, not really understanding the differences in diagnostic criteria, not really querying about it. What also complicates a lot of these scenarios is that individuals might also have undiagnosed genetic disorders. And so we'll also do a genetic workup to see if there are any genetic markers or gene mutations that result in a gene deletion syndrome, some sort of a genetic syndrome. So in some of these situations, we'll see a multitude of factors: a child with a genetic syndrome plus fetal alcohol spectrum disorder. And that interaction and how it impacts the child can complicate their clinical presentation even more. A lot of times, you know, there's been some studies looking at children that are in the foster care system. And because of the complexities of their biological families' lives, there has been an increased preponderance of FASD in this community of children. When they've also done studies of children from certain international orphanages in different countries, there too, they have seen, you know, in certain studies in Russia and Ukraine from international adoptees from this area, I think up to 50% of the children met criteria for an FASD. That would also be, I would say, another red flag. But I would, moreover, just really emphasize for any child with a developmental, intellectual, or behavioral concern, they really deserve that inquiry of their birth history to find out if there were any alcohol exposures during pregnancy. And absolutely, you know, as has been said, it must be ascertained with great sensitivity so as not to shame anyone. That is completely unfair. And I think it also has to do with mixed messages in the public, in the media, and the lexicon about how much alcohol is appropriate during pregnancy, when the answer is really none. But there are mixed messages, I think, from healthcare providers, unfortunately, and there are efforts underway to really rectify that problem. I actually talked to a healthcare provider last year at a conference who he himself said, you know, my mom drank during pregnancy and I turned out fine. So there can be sort of a block or a disbelief even in not knowing the science of this entity. So awareness is a big part of the problem too. But all this to say, it is just a standard part of the intake for every single patient that I see in my practice, because with alcohol exposure and developmental behavioral problems, I mean, they basically have FASD. So those were the main points I really wanted to emphasize. I'm happy to turn it over to the moderator to introduce the next speaker.
Thank you, Dr. Valdez. That was outstanding, and I think really gave our participants a good idea of what you specifically do and think about because of your knowledge of FASD. So thank you. And there's going to be some questions I think we can direct to you. I'd like to stop the recording now.